So I think we're all looking for a novel immunotherapy, and CAR-T, of course, has been a paradigm shift in malignant hematology as far as treatment with lymphoma, myeloma, acute lymphoblastic leukemia. So there are trials ongoing. Most actually right now are AML, although there's a high degree of overlap. I think we need to often get past this arbitrary separation between MDS and AML. And if we think about many of the antigens that are being targeted, there's likely relatively similar expression in the MDS patients, especially higher risk patients. So the main single antigen CARs thus far have been CD33, CD123, CLL1. There has been some data across particularly CD33 that has had some responses. So for example, there is a Precigen Ultra CAR T cell, which is sort of a rapid manufacturing process we've been a part of. We presented data at ASH this past year where around a third of patients in the lymphodepleted cohort had remissions, although the durability I think needs to be longer. It was around 3 months. So dose escalation is ongoing in that study, and the potential to dose patients multiple times I think is very relevant. This is actually one of the only studies that allows high-risk MDS patients. We're actually in process of treating some of those patients, but no data to date as far as safety and efficacy, although safety should, if anything, be better in this patient population. Again, what the ultimate efficacy is, I think, remains to be seen. I think in many of these other CAR strategies, they're sort of going after sort of the standard relapse refractory AML patients. Again, a lot of these have very high blast burden, so I would argue that we should really try to move this into the MDS space as soon as possible. Again, I'm not aware of any data with 123 or CLL1 to date, but I would look forward to that. I think ultimately the challenge is there's no uniform antigen, so there's no perfect marker like CD19 or BCMA. I think most likely what's going to be needed to really pass these efficacy thresholds is sort of OR gating with a CAR that will activate on targeting more than one antigen. If I was to pick two, I would like CD33, CLL1 combination, but I think there are a lot of other ones. There's also some novel targets that are ongoing. But I think instead of focusing on safety, we really have to focus on efficacy to try to get to where some of these other diseases. But again, I think the future's bright. I think patients need to be highly referred to centers that do have some of these trials open so that we can try to move this as quickly as possible. It's a very slow and challenging process getting through dose escalation, but again, hopefully we'll have some more data in congresses in the near future.